So next, I would like to introduce Dr. Evelyn Taiwo, who is an associate professor of medicine at Weill Cornell Medicine, an attending physician, and a director of the Hematology-Oncology Fellowship Program at New York Presbyterian-Brooklyn Methodist Hospital. After completing her medical training at Temple University School of Medicine and residency at Boston University Medical Center, Dr. Taiwo completed a 3-year fellowship in hematology and oncology at the University of Texas Southwestern Medical Center in Dallas, Texas. She's previously served as an assistant professor of medicine at the State University of New York, Downstate Medical Center in Brooklyn, and an attending physician at Kings County Hospital. While at Kings County, Dr. Taiwo served in a leadership role as a director of the Breast Cancer Center, overseeing operations, research activities, clinical care delivery, and education. So in addition to clinical care, Dr. Taiwo's work addresses disparities in breast and healthcare with a focus on improving clinical trial enrollment, community engagement, and patient advocacy. As a researcher, she's contributed to several studies on cancer presentation in urban and minority patient populations. So Dr. Taiwo's talk today will be entitled Palliative Care in Oncology, the Nuts and Bolts. Welcome, Dr. Taiwo.
Thank you. Thank you so much. And happy Bloodless Medicine and Surgery Week. I will share my screen. And I will start the presentation. Can you all hear me and can you see my screen?
Very well.
Fantastic. So as Rebecca mentioned earlier, I'm a medical oncologist. I actually with an expertise and focus in breast cancer. So I am kind of out of my realm here, but this was it's an honor to be here talking about palliative care. You know, I work in Brooklyn, New York, and prior to moving to Weill Cornell Medicine, I worked at a safety net hospital called Kings County, where majority of my patients were underserved immigrant patients, mostly from the Caribbean. And I say this just to talk about what really piqued my interest in palliative care in cancer. Many of my patients would come in with metastatic disease. They were coming in with incurable cancers, but treatable, but incurable. And, you know, the need to focus on how to manage, how to care for these patients, but also making sure that the toxicity of the treatment didn't really outweigh the benefit of the treatment that we were giving. And that's how I came into palliative care as a medical oncologist. I have no disclosures today. And, you know, when I got the invite to give a talk here, I wondered, I said, well, what does palliative care have to do with bloodless medicine and surgery? And I kind of did a little bit of a deep dive myself into bloodless medicine and just kind of understanding it. Bottom line, it's very medical. It's this, you know, first do no harm, right? I mean, everything that we do, that really is the underlying charge, and which exactly is what palliative care is as well. And it made me understand this connection between why giving this talk on this platform was important. So for the rest of my talk, I'm going to just focus a little bit on just what palliative care is, the goals of palliative care, who is eligible, and some of the palliative care interventions that are important, particularly, patients who have been diagnosed with or living with a cancer diagnosis. It's a very, very basic question. What exactly is palliative care? There is a lot of myth about and confusion, not just with patients, but doctors as well, about what palliative care is. People hear that word and there's a concern that, oh, that means there's there are no treatment options. You know, when you're talking to a patient about palliative care, the fear is that you're getting to a point of their treatment where you're suggesting that we do absolutely nothing for their disease, which is completely far from the truth of what palliative care is. But palliative care is, you know, it's been defined by the Multinational Association of Supportive Care as supportive care in cancer, which is just the prevention and management of adverse effects of the disease itself, that's cancer, and then the treatment of cancer, which could be chemotherapy, could be immunotherapy, could be targeted agents. It's a focus on management of physical and psychological symptoms of the side effects across the continuum, right? So not only is it an intervention that should or is offered at the end of a patient's life, but it's a service that really should be provided to patients from diagnosis through treatment to the post-treatment phase. And its focus really is on enhancing rehabilitation, secondary cancer prevention, even in the survivorship phase when patients are no longer with active cancer. But of course, the end of life care is a huge part of what palliative care is. So all of this is what encompasses what palliative care is. It's really just supportive care, managing physical, psychological, emotional, spiritual from the time of diagnosis to the time of death for the patients who succumb to the disease. This is a nice cartoon that shows what, it all means when we talk about palliative care, when we talk about supportive care, when we even talk about hospice, because those things really do get confused. Supportive care is just any care that is supporting a patient at any time of their diagnosis and treatment. So palliative care and hospice care are all under supportive care. So whether a patient has disease or no evidence of disease, we know that supporting them through their diagnosis and treatment is beneficial. Palliative care, for the most part, even though you can provide that at the time of diagnosis, is generally an intervention or service that's provided to patients who have incurable but treatable cancer. So that is the difference versus hospice, which is a service that's also supportive, but it's offered to patients when they are at a point of their diagnosis where intervention is likely going to cause more toxicity and is unlikely to improve their overall survival. And that's care that's offered to patients when they're getting closer to end of life and when we're talking about bereavement. So that's very different from what palliative care is. And I think this is the confusion that occurs with doctors, with patients, where there is a fear of having a conversation about palliative care. This is just another slide that really defines and separates what palliative care is from hospice. With palliative care, it's patients that are living with life-limiting illness, but their prognosis could be good, could be poor. It's really to maximize quality of life, maximizing support, whether it's community, familial support, symptom management, spiritual health care is a big thing, as well as psychosocial support. Very important when we're talking about hospice care. It's generally care that's offered to patients that have less than 6 months to live. So within weeks of months, with weeks or months to live, that's a very different kind of care. Sometimes ongoing medical treatments are given. Oftentimes, any intervention that is not going to improve or help the patient in terms of their symptoms is not offered when they're in hospice. It's really symptom management as well as spiritual and psychosocial. So it's similar to palliative care in that sense. The big difference is that with hospice, these are patients that are closer to the end of life. They generally have weeks or months to live, and generally medical treatment is not provided because it's not going to change the outcome. It's very different from hospice. And this is just a nice, I love graphs, I love pictures, I love cartoons, anything that makes, things appear simpler. So palliative care, like I mentioned, it's specialized medical care focusing on providing relief. I think it's important to know that it encompasses different groups of providers. It's care for life-threatening illnesses, but also focus on not just the patient, but as well as their families. You can provide this care at home, at health centers and hospitals. It improves quality of life. I will show some data evidence to show that it is beneficial. It also benefits health systems in terms of cost reduction, and it can be provided by many types of health professionals as well as volunteers. So the patient and the family are the focus of palliative care. Involves interdisciplinary group of providers, obviously physicians. Social workers are absolutely important in this setting. therapists, pharmacists, nurses, spiritual counselors, particularly where you are in communities or cultures where spirituality is important. It's absolutely a must. It's imperative to include spiritual counselors and support in palliative care. I think for us as, scientists and medical folks and clinicians, there's always that. We talk a lot about evidence-based medicine, which absolutely is important. And sometimes we minimize the importance of spirituality, particularly to a lot of patients. So when we start talking about palliative care, it's no longer about what the physician thinks. Obviously, that's an important part of coming up with the plan, but a lot of the focus is on the patient and their family and what is important to them. The WHO, has also put out statements because there's clear evidence showing that improving quality of life of patients and their families when they're dealing with life-threatening illnesses is absolutely important. So there's been the recommendation to provide this supportive care and palliative care very early on. We want to identify those who are suffering. We want to do that very early at the time of diagnosis. We want to assess those patients aggressively and treat pain and other physical symptoms or psychosocial symptoms, as well as spiritual needs. Palliative care can be provided when patients are actively receiving treatment. It's not one or the other. We provide the support while the patient's actively getting treatment. And the most important thing, like I mentioned, is matching the treatment options to the patient's goals. It's really about what the patient, their family, their loved ones think is important. The goals of palliative care are to, advance care planning, patient goals. I think when patients have been diagnosed with serious illnesses like cancer, a lot of power is taken away from these patients. You get a diagnosis, you're evaluated, assessed by, clinicians, and all of a sudden, those people take over your care and essentially take over what your life is going to look like for the next few months, years, or however long you have to deal with the disease. Palliative care is a way of giving patients some agency, some power. Once those conversations start happening, you get a sense of what the patient's goals are. So you're there to help them drive the car while they're telling you exactly what their priorities are. So really, the goal is advanced care planning. But obviously, minimizing suffering is a huge part of it, maintaining dignity and respect. And a lot of it is based on the needs of the patients, not necessarily on the prognosis. So it's not based on how long we think they're going to live, the number of weeks or months. That's more hospice. Palliative care is really just based on the needs of the patients at any given point during their diagnosis. It's appropriate at any age, at any stage in a serious illness. It focuses on the quality of the patient's life, not necessarily the quantity. And like I mentioned previously, we can initiate palliative care services at diagnosis throughout treatment, as well as end of life, where you can then transition patients to hospice. And the importance of palliative care, I think, is very clear in the field of oncology. Even the NCCN guidelines and the American Society of Clinical Oncology have all updated clinical practice guidelines in terms of when palliative care should be initiated. They recommend inpatients and outpatients with advanced cancer. So anyone who's coming in with metastatic disease should receive dedicated palliative care services early in the disease course, concurrent with their active treatment. So it's become standard of care now. A patient comes in, it's very different from a patient who's got early stage disease, where a treatment plan is very clear from the get-go, whether there's going to be surgery, whether there's going to be radiation, chemotherapy, to the in terms of treatment. For patients that are metastatic, they're going to live with the disease indefinitely. So it becomes almost like a chronic illness. So these are the patients where palliative care interventions should be initiated at the get-go. Even if there are no identifiable needs at that time, there will be needs eventually. And so these, initiating this consult and the services early on and establishing this relationship so that the patients can then reach out when a spiritual need or physical need or financial need arise, set up rather than chasing after it when the need, arises. And in terms of just, why we are such advocates for palliative care, and not just because it makes sense that integrating early palliative care into treatment plans in advanced cancer is actually associated with, improved, like we talked about, quality of life, mood, less aggressive end of life care. We know here in the US, we spend so much money at the very end of a patient's life that doesn't really benefit them or benefit the patient at all. So if we can, reduce the cost or necessary cost, I think that would be helpful to the patients. There is financial toxicity associated with a diagnosis of a serious illness. So we prescribe drugs, we recommend interventions, and patients, even though, most patients have insurance, it's not free. There's still co-pays. And so reducing costs to the patient is also something that palliative care is helpful and useful for. But it does decrease caregiver stress, and it improves overall survival when provided early. And you could see this Kaplan-Meier curves here showing survival analysis of patients who got early palliative care versus patients who got standard care. These were patients who had, in this case, this was a study in metastatic lung cancer patients. And you could see that overall survival was improved in patients who got early palliative care. Then the graph next to it was assessing quality of life, anxiety, and depression in patients who got standard care versus patient who got standard care and early palliative care, right? So they're still getting their, whether it's their chemotherapy or radiation or immunotherapy, but they were also getting palliative care intervention, whatever the needs were in that particular patient. So whether it was psychosocial, whether it was a mental health need, whether it was a financial need, whether it was coming up with advanced goals of care conversations, so the patient felt empowered. So those were things that were those were the interventions that were offered to those patients who got palliative care intervention, and it did lead to decreased quality, improved quality of life, decreased anxiety, and decreased depression in those patients. And this here is just showing, if you look at the bars, it's patients, once again, who had metastatic disease, who got spiritual support from the medical team, who got pastoral care services, and those who got both pastoral care services and spiritual support. And you could see very clearly in the blue that patients who had the spiritual, pastoral, and combined support had improved quality of life at near death, which is so important when patients are dealing with serious illnesses and really confronting their mortality. So we have the evidence to show that it works. It's not just that it sounds good in theory, but there is data that shows it works. Now, why don't we do this more as oncologists? I think, it's hard to talk to patients about end of life and their mortality and goals of care, right? Talking to a patient about their goals of care is the acknowledgement and, in a way, admission that it's unlikely that you will be here for a very long time. But some of the reasons that oncologists have come up with is that people don't want to know. It will make people depressed. It will take away their hope. Some patients will die sooner. It's not culturally appropriate. But the facts actually is that most patients do want this information. And there's data showing that depression and anxiety are no more common. People who are aware of their disease. That hospice and palliative care are associated with longer survival, so patients will not die sooner by having that information. If they want to have that information, we can we can be honest and still be hopeful at the same time. And it's always culturally appropriate to ask. I think, when we're having sensitive conversations, the most important thing to start off with is asking the patient, how much do you want to know about your illness? And I've been pleasantly surprised. Most people want to know, even people that I thought didn't want to know. There are some patients, they are a minority, who will say they don't want to know, don't talk to me about it, whatever happens, happens, or talk to my daughter, talk to my husband, I don't want to know, and then we respect their wishes. But I think it's important to always ask, how much do you want to know about your illness? For many people, knowing and making decisions and setting up their future, if they have young children or family members that they feel responsible for, is a way of giving them that power to make decisions. But in terms of feeling hopeful, there was a study that looked at patients who got, information about their disease and their prognosis, and you could see really no difference in how hopeful people felt, including patients who had poor prognosis. I think it's important for us to develop the skills to have this basic conversation, such as, asking patients, what is your understanding of your situation? How do you like to get medical information? What is important to you? What are you hoping for? Just, having conversations about prognosis, goals of treatment, what suffering means to them. It's different for everyone. And I think doing that allows patients to feel like they're part of the conversation. You're a team with them. You're not doing things to them. You're doing things together for them. And that really changes the energy, changes the dynamics. It changes the trust that a patient has in their physician. And having that trust in their physician does help that patient in terms of their quality of life. I think trusting your physician and feeling confident in decisions that are being made about your health, I think improves your general understanding and feelings about how you think you're going to do. So these are the kind of open-ended questions that I think create bonding between doctors and their patients, and you get to know them, what they want, and you can then advocate for your patient as well. And this is just showing the reduction in cost. So if we want to sort of even just talk about the bottom line and talk about finances, which at the end of the day, that's always an important thing, that you actually see that post-palliative care cost, really for patients who got usual care versus palliative care, that the cost of the medical care actually was decreased in patients who got palliative care. And these were in patients, older adults with advanced cancer. This was a study that was published in the American Journal of Hospital Palliative Care in 2021. And this, I think, was the study that really, I think anytime you're talking about, if there's this intervention in general, it actually saves, money, I think people start listening. And I think over the last 3-4 years, palliative care and the importance of palliative care has become, more mainstream, even though, palliative care physicians, which I'm not, we do have palliative care doctors, but we work very closely with them. And this is something that I'm passionate about. So I'm also, I'm also there advocating for patients and then referring to palliative care physicians if there are things that I think they may be better at handling than I am as a medical oncologist. But this study showing the cost savings associated with palliative care, I think has just led to everyone now wanting palliative care involved in caring for all their patients, which it's a good problem to have because the patients do benefit from it. So in terms of eligibility and who's appropriate for palliative care, I mean, we're talking about oncology, at least that's what I'm talking about. So the population that I focus on are patients with advanced cancer, patients with a lot of symptom burden from their disease, but there are a slew of patients who can benefit from palliative care, not just patients with cancer, patients who've got chronic pulmonary disorders, your patients with, chronic obstructive pulmonary disease, your COPD patients, your patients with pulmonary hypertension and pulmonary fibrosis. These are patients with chronic illnesses that affect their quality of life in such a negative way that anything to support them is absolutely important. Your patients with advanced renal disease who may be now requiring dialysis, your patients with congestive heart failure, patients with end-stage AIDS, liver disease cirrhosis, patients who are no longer candidates for liver transplant, patients with neurologic disorders, your post-stroke patients, your patients with dementia, patients with neuromuscular disease, and patients coming in with multi-organ system failure definitely benefit from supportive care. I think sometimes we forget that, patients who, lack the financial means to care for themselves, sometimes you write these prescriptions for patients and you're like, oh, they come back and they haven't taken their medicine. And there's this frustration that there's something you can do, but the patient is not compliant, as we call it. Sometimes it just requires having, a social worker talk to the patient to get to the bottom of why they're not picking up their medicine. And then you find out, well, they actually cannot afford the medicine. And if you're in an environment where there is, some sort of safety net or support that the patients can get, that may be all that they need. And so these are the kind of patients that are, eligible and appropriate for palliative care. And then when there's a conflict in the goals of care, you as a physician may think, being slightly more aggressive is beneficial to the patient, or maybe not. And the patient is agreeable, but then there's a family member who doesn't think so, even though the patient is your primary priority. There are all these people surrounding them that are trying to make decisions on behalf of a patient who still has capacity. Sometimes getting them into, palliative care services where there is a social worker, there is a mental health expert, there's a spiritual counselor, to kind of really tease out what the problem is so that you and the patient can make better decisions for the patient and not necessarily for the patient's family, even though they're all part of the team. So anytime there's conflict in managing a patient, getting palliative care involved is usually very helpful, because then they can really dive really deep to get to the bottom of things and really help solve some of those problems for us. So in terms of when you should consider palliative care consult, I already kind of spoke about that on the previous slide. But I think in addition to all of that, when you do have a care team, which could be the doctors, the nurses, the pharmacists, those that are primarily responsible for the patient's medical care, anytime that team and the patient or the family, anytime there's a need for complex decision making and determining goals of care, I think having palliative care consult is important. Sometimes when there's uncertainty about end of life, uncertainty about appropriateness of the therapy options, sometimes patients come and they want everything, and that whatever intervention they're requesting is unlikely to benefit them. It's likely going to be more toxic, and you're having a difficult time communicating that to the patient as a physician. Some of us are very well equipped to do that. Some of us aren't. When you're not, that's when you want to get a palliative care consultation in there. Anytime you have divergent views over care, which is essentially the same thing, there is conflict, it's important to get palliative care as a third party. I think part of having palliative care involved also from the very beginning, even when there are no active needs, is that when you get to this point of divergent views or conflicts, you already have a palliative care team that knows the patient, that has been present from the very beginning, and they're not just showing up as strangers when things are not going in the direction that you think it should go as the primary care physician or oncologist, whatever specialty for that patient. I find that having palliative care involved from the beginning, even whether it's just to introduce the patient to them so they know they know of each other, really helps when things get difficult, because you're not now bringing in a stranger into this conversation. The patient is already aware of what the palliative care team, what they do and why they're present. And it's absolutely important to have palliative care involved when there's metastatic cancer with no response to treatment, and you are now at a point where you need to start having some difficult conversations. I think traditionally that's how we were using palliative care. I think more and more we're getting them involved from the very beginning, so that when you get to this, multiple regimens of treatment are no longer active, they're very quickly in the mix to help us take care of this patient and make some difficult decisions for the patients. So moving on to some of the symptoms in advanced care that I'm not going to talk about all of them, but there are a couple that I think are important for us to be comfortable in managing. Right. So patients with advanced cancers will come in with asthenia, anorexia, lack of appetite. They sometimes lose a lot of weight. Pain is so debilitating for many of our patients with advanced cancer and grossly undermanaged. So I will talk a little bit about that. Nausea, constipation, sedation from pain medicine sometimes, and then the dyspnea that sometimes patients experience from pulmonary disease. But I think pain is something that we could do a better job of managing. And I'm going to talk a little bit about pain when I talk about some of our interventions. So palliative interventions, when patients are metastatic, chemotherapy is a palliative intervention in someone who's got metastatic disease. So they are not curable. You have stage 4 breast cancer, you have stage 4 colon cancer. So this is not a disease that's going to go away completely, because this is now widely metastatic, but it's treatable. And what you're doing by treating is to reduce tumor burden. And by reducing tumor burden, the patient's vital organs are able to function and the patient's able to be active. Many patients are on chemo, they go to work. They're still functioning members of society. So it is a palliative intervention. I think sometimes when people think of chemotherapy, they think of it as being, oh, this is very aggressive treatment. And sometimes it is, and many times it's not, particularly when patients are metastatic. The goal of treatment at that point is finding a treatment that the patient can tolerate, but that's also going to control disease. I have patients who've been on chemotherapy for 5 or 6 years. Every 3 weeks, they're getting their treatment, and somehow they still have stable disease or no active disease. So it's a palliative intervention, right? So the chemotherapy, the antibodies, the endocrine therapy, it's not always chemotherapy. There are many non-chemotherapy drugs in breast cancer and in prostate cancer. We use endocrine therapy. We use antibodies in some other types of cancers. So chemotherapy is not just one thing. Systemic therapy is medicine that we give patients that goes into the bloodstream and systemically. Chemotherapy happens to be one of them, but there are many non-cytotoxic treatments that we give patients who are metastatic and is considered a palliative intervention. Sometimes radiation will be palliative. Someone's got a lesion in their hip, and even though it's metastatic, but it's very painful, we'll radiate that lesion for pain control. Sometimes some surgical interventions are palliative, because any intervention in a patient who's widely metastatic to improve symptom, to control pain, to improve quality of life is considered a palliative intervention. Now, if you move to the other side of the screen and you look at the potential palliative care interventions, we've talked about emotional, spiritual, psychosocial support. We're talking more about now controlling pain, shortness of breath, nausea, vomiting. And then you see some of the interventions that are generally not palliative. When we start talking about doing CPR in those patients that are, that have a lot of disease burden, putting them on ventilators, just highly burdensome interventions are generally not palliative. So these are interventions that we try not to engage in when patients are presenting with metastatic disease, particularly if it's active disease where the disease is not very well controlled. You really don't want patients getting aggressive measures or interventions for a disease that you're not going to be able to control. Then they have those variable interventions. I love that, transfusions is one of them, since, a lot of the conversation this week is going to be on blood transfusions. And I think for us in the US, because we have access to blood transfusions, we have access to a lot of things that may not be available maybe other, maybe middle or lower income countries, we just throw everything in. But we're seeing that these really should be variable interventions because transfusions are not always beneficial. I'm sure there are going to be others talking a lot more about the pros and the cons, but I think it's important for us to really sit there and think, is this actually helping? Is this actually palliative in this setting? And so these are the questions that, any palliative care physician and any oncologist with the palliative care mind, knowing that that's important to their patient's outcome, will spend time thinking anytime you have to make this decision. So I just want to talk a little bit about pain, because pain is a huge part of what patients with advanced cancer deal with. And it's something that oftentimes is undertreated. And there are many people who feel very strongly about controlling pain. Dr. Catherine Lee Gailey Camus, who was the WHO's Assistant General, Director General, mentioned, I love her definition and her assessment of what relief of pain is and why it's a right. And she says physical, emotional, spiritual, and social control is a human right in terms of the relief of pain, because the relief of pain allows patients to exist in all their physicality, emotional space, spirituality, and their ability to be social. And this she considers a human right, which I agree with, that everyone has a right to be treated and to live or die with dignity. And that's impossible to do when there is significant pain. Palliative care is one aspect, and controlling pain is a huge part of what palliative care does, besides all the other things that we've mentioned earlier. So palliative care is an urgent need for people living with advanced stages of cancer, particularly in developing countries, because there's a high proportion of people with cancer. They're being diagnosed when treatment is no longer effective. Many patients are coming in with higher stage disease. So the importance of palliative care, the importance of pain management is something that should be recognized in those settings. It's been estimated that about 5 million people suffering from moderate to severe pain caused by cancer do not receive treatment. So if many patients in these communities are getting diagnosed with high stage disease, and we know that many of them are coming in with pain, that means there are way too many people that are living with pain with their disease, and we need to do better than that. The WHO projects that cancer deaths will continue to rise, with an estimated 11.4 million dying by 2030. 80% of those patients are going to be in low and middle income countries. And 60% of people living with cancer live in these countries, and they have minimal access to pain and symptom management, which means far too many people are living with intense suffering and pain. And when you actually look at the use of narcotics, at least morphine, when you look at the morphine equivalents, you can see on this graph the amount that's being used in the US compared to Japan, compared to Nigeria, which is almost like non-existent when you look at the morphine equivalents, that we all need to do better, all of us, in managing pain in our patients that have been diagnosed with advanced cancer and just other types of diseases that are associated with a lot of pain. The inability to control pain basically negates whatever it is that you're doing to control a patient's disease. If pain is active and not controlled, giving them chemotherapy and whatever intervention to manage their disease is not doing much for their quality of life and their desire to want to live and live with dignity. So we need to make sure that in addition to all the palliative care interventions that we've talked about, that pain control is also considered an important aspect of managing this patients. And this is just a slide showing basically what I mentioned previously in terms of opioid consumption. It's an opioid consumption map. And when you look at it, the blue is North America, and then you could see Australia and then parts of Europe. But when you look at other parts, blue are countries that have lots of morphine use and access to morphine. And then when you look at other parts of the world, the numbers start going down. And then the countries in white don't even have any data. And so not sure, how patients are being managed in some of those countries. but we need to get the word out, and we need to do better in managing pain. Pain is now considered, the fifth vital sign. It's you're getting their blood pressure, you're getting their heart rate, you're getting their respiratory rate, their oxygen saturation. Asking about pain is now considered a fifth vital sign, and I think we don't do a good enough job of documenting and asking people about their pain. So, well, what can we do to relieve pain? We know that 30% of patients with newly diagnosed cancer will present with pain. About 70% of those patients are receiving active therapy, and up to 80% are in advanced disease. So how can we manage something that exists in so many of our patients? And, the WHO again has demonstrated that most patients and most of cancer pain can actually be relieved if we implement an available pharmacologic approach. It's very inexpensive. It's practical. It's one that I use, and it's something that can be used worldwide, where we use this three-step ladder to categorize, pain level. 1 is mild, 2 is moderate, 3 is severe. Someone's coming in with mild pain. It's very easy to manage, whether it's with, acetaminophen, Tylenol, your non-steroidals, anti-inflammatory agents, the ibuprofen, aspirin. The pain is moderate. Then you start adding, slightly more active pain medications, the codeines, the hydrocodone, oxycodone, tramadol. If it's severe pain, then you escalate to more of the morphine, hydromorphone, methadone. And then, we talk very passionately about the need to manage pain control, but we are also aware of the addictive potential of some of the opioids that we do use. So it's absolutely important to assess patients, assess their pain, and escalate as needed. Most patients won't even need to get up to the severe level of having to be on a narcotic that they can get addicted to if the pain is addressed when it's still at a mild level. Oftentimes, we don't do that. Oftentimes, patients also don't verbalize their pain, and oftentimes they'll verbalize the pain when it's now extreme, and you have to prescribe the bigger, more intense narcotics. But in terms of the steps, you start with step 1, it's mild pain. You use, like I said, the non-opioid drugs such as acetaminophen and the non-steroidals. If the pain is persistent, you escalate to the second step, which is with the weak opioids. And you can use this weak opioids in addition to the non-opioid agents. I oftentimes will give hydrocodone and ibuprofen together and tell patients to alternate. Non-steroidals are highly underrated. They really work well for pain control. So mixing that and alternating sometimes is all a patient needs, that you never have to escalate to the step 3. But sometimes patients are presenting that way, or your combination is not helping. Then you move to the strong opioids, which would be your morphine and the hydromorphones and all of that, which you can use for a short period of time. But in patients who are metastatic, who are in chronic and constant pain, who their overall prognosis is poor and maybe have just a few months to live based on your experience and knowledge of their disease, I think addiction really is not an issue and is not a concern for palliative care physicians and palliative care providers when you're dealing with patients at that level. Because some of the counter argument is, oh, well, we're worried about our patients becoming addicts. It's like, well, if the patient's end of life is, 3 to 6 months from now, that is not priority, right? And these are not, the patients that you're worried about, addiction potential are often not the patients that require a lot of, of narcotics. Your early stage patients are treated completely differently. This model is for your patients with advanced cancer. They're coming in with bone lesions, everything hurts. They're coming in with disease burden in the liver, in the lungs. They've got ascites, just all of that. They can't sleep because they're in pain. I think talking and being concerned about addiction becomes less of a priority in that setting, but I think it's an important conversation to have. It's important for patients to know the strength of the kind of medication they're on and the pros and the cons of the medications they're on and the importance of being responsible while using these drugs. This is a table that shows, I mentioned pain, obviously anorexia is a big thing. Patients do come in and they are worried that they're losing weight on a daily basis. They're starting to look cachectic. They're embarrassed to go out because they don't like how they look physically. They look very different from how they looked before their diagnosis. This table is very helpful. It shows the doses and the uses of appetite stimulants in patients who've developed cancer-related cachexia. Sometimes just using steroids, just prednisone, dexamethasone, methylprednisone is all that you need to help a patient actually improve their appetite. We use Megace a lot, which is, it's a progesterone analog. It can increase the risk of blood clots. So I am very careful, and it's not my favorite to use, but sometimes we'll use it. Then you have some data for cannabinoids, the THC derivatives, the medical cannabis. There's still a lot of research that's happening in that space, but the THC, there's a prescription drug, it's called Marinol, that we do use twice a day, and that is something that is approved. We write by prescription. They don't need to go to a dispensary to get that. But in terms of how medical marijuana actually works, I think that's still debatable, and that's not something that is mainstream right now. And then some of the serotonin antagonists, like olanzapine, have been shown to stimulate appetite in patients with chronic diseases. So these are some of the interventions that, as we're giving chemo to the appropriate patient, managing pain, that we're also supporting patients in their appetite, because the anorexia is always of big concern to patients. So I will end my talk with my summary being that palliative care is important and it's beneficial to all. I know it says breast cancer patients, but to all cancer patients, multidisciplinary teams, nutritionists, psychologists, pain management, palliative care specialists are important, really important in advocating and implementing palliative care services. Early introduction of palliative care is important in patients with cancer. We have data showing that it improves quality of life and likely improves survival. And I think, just as a reminder, which I think it's what this symposium is about, is, really to remember first to do no harm. So that is the end of my talk. And thank you for being here with me.